This conference will now be recorded.
Hi, this is Mel Green. I want to know, are you in the mood? We're going to talk about PHQ-9 for social workers and other IDT members. How do you think we're doing compared to 1,400 other nursing homes across 41 states in regard to how we capture depression in our residents? Well, we don't need an 8-ball to figure it out. We have CORE. CORE is an analytical vendor that has greater than 1,400 facilities in its portfolio. This is CORE's PHQ data for TRIO, reflective of August 1st through October 31st of this year. So when you look at this, it's saying 8-ball, the outlook is not so good. This is us compared to CORE in August, basically half of where they were. We seem to do a little bit better in September, and then look at October. Can this be right? I wanted to call your attention to an article that was written in regards to an Alzheimer's and dementia doctor. It's a doctor's view of depression in long-term care residents. And the reason I wanted to bring this to your attention is because so many staff feel as though there's some sort of stigma or that there's an indicator that you're doing something wrong in the facility when a resident demonstrates some sort of a depressive symptom. You feel as though we're not giving them the right medications. We don't have the right activity program. When in fact, this doctor would tell you that as a geriatric psychiatrist, he has worked over 30 years in long-term care. And approximately 20% of nursing home residents have major depression. And then an additional 30% have significant depressive symptoms. So that means in any long-term care facility, every other resident is likely to have some form of depression. And the fact that that could be exacerbated by a behavioral outburst, something else that might mask what actually is depression because they have dementia. So we think that they're acting out when in fact that may be a demonstration or them exhibiting actual depressive symptoms. So you need to be able to make sure that you're able to differentiate between those things and identify them without having any sort of a feeling as though they cry for a certain reason. They do this because of a certain reason. We don't want to normalize any of those things, and we want to make sure that we're addressing them fully. So let's do a refresh on our interview process and techniques, and then continue to check our stats over the next 3 months. I completed an audit of all the TRIO facilities related to whether or not a patient could be interviewed, being coded as a 0, or a patient completing an interview being coded as 99. In both of these situations, staff assessment for mood would need to be conducted. So I used MDSs with ARDs of August 1st to October 31st to match that core data. 87% of the residents successfully completed a PHQ-9 interview, and that is awesome if it's been done correctly. 13% were not interviewed or were unable to complete the interview. Based on the current core data from the previous slide and these findings, we decided to dedicate some additional focus to the PHQ-9 interviews and reinforce when and how you should complete the staff assessment, conducting staff interviews as opposed to relying on documentation that is inconsistent and more often than not missing from PCC. And to be clear, you do not need to have a diagnosis of depression or be on an antidepressant to present with symptoms. Although there is financial interest in this data being accurate, make no mistake, there should be a prevalent clinical and psychosocial focus as we look to ensure residents' quality of life. So interviewing the patient. We're going to start by explaining the reason for the interview to the patient. The suggested language from the RAI is that I'm going to ask you some questions about your mood and feelings over the past 2 weeks. I will also ask about some common problems that are known to go along with feeling down. Some of the questions might seem personal, but everyone is asked to answer them, and this will help us provide you with better care. Next, you begin asking the questions exactly as written. No need to go ad lib and off script. The RAI is very specific to show you. Say to the resident, over the last 2 weeks, have you been bothered by any of the following? If they answer no to a symptom, proceed to the next symptom. Do not provide definitions because the meanings must be based on what the resident thinks you mean. What's their interpretation? For example, the resident decides what's considered tired or overeating. If they answer yes to a symptom, you must establish the frequency before you proceed to the next symptom. Frequency is what's going to make the difference in whether or not you capture depression under PDPM methodology. So once you've asked them if over 2 weeks they've been bothered, now you're going to say, about how often have you been bothered by this? Read and show the resident a card with the symptom frequency choices. I cannot express enough how important this is. Think of yourself right now, cognitively intact, picking up the phone to call and deal with something of a personal matter. Let's say you're calling your bank and they say to you, please listen to our menu as it has changed. Press 1 for this, press 2 for this, press 3 for that. Now you're thinking, oh, 3 sounds like what I need. Let me write that down. 4 for this, 5 for that. Oh, I can't remember. Well, maybe I need 5. 6 to return to the main menu. I better listen to that again. And you could go through that cycle. That's exactly what's happening when you're asking a patient who's cognitively impaired or trying to mask cognitive impairment what it is that they're feeling for a 2-week period of time. So it behooves you to hand them something for their responses so that they're able to reasonably look at that and either point to say that it's a 1, a 2, or a 3, use the words of several days, half or more of the days, or say 12 to 14. Without that card, you'd never know if the patient is masking their cognitive impairments and just picking the first answer or the last answer that they remember. Okay, so cognitively impaired patients, you could get skewed data if you're not giving them a cue card to use. So I'm sharing that with you when I send this PowerPoint so that you have them available, and I highly suggest that you use them. So again, symptom frequency, a 0 is never or 1 day, 1 is 2 to 6 days or several days, a 2 is 7 to 11 days, which is half or more, and 12 to 14 is nearly every day. If the resident has difficulty selecting between 2 frequencies, you code for the higher. So if they say, I don't know, half or more of the days, maybe it's every day. If they can't decide, it is appropriate for you to take the higher of the 2 frequencies according to the RAI guidance. Even though there are only 9 questions on the PHQ-9, some questions have multiple depressive symptoms that are tangled into one. So look at trouble falling asleep, trouble staying asleep, or trouble sleeping too much. There's 3 questions on one line, and you can only give one answer. If a resident gives different frequencies for each of those parts, you're going to select the highest frequency as the score for that line item. So for an example, symptom frequency again is 0, 1, 2, or 3. They had trouble falling asleep, never or 1 day. So you're thinking, okay, well, that would be a 0. But they've had trouble staying asleep 2 to 6 days. So that's a 1. And then sometimes they feel like they're sleeping too much, 7 to 11 days. That's a 2. You would code 2 for the question because it is the highest frequency, and it's perfectly appropriate because that's what the patient indicated to you. So again, you need a frequency score of 10 to capture depression under PDPM. The interview is successfully completed if the resident answers the frequency responses for at least 7 of those 9 questions on the PHQ-9. If symptom frequency is blank for 3 or more, the interview is deemed not complete. The total severity score at DO300 gets coded as a 99, and the staff assessment of mood needs to be conducted. So interviewing staff, you will notice the questions are the same with an additional question related to being short-tempered or easily annoyed. Everything else is pretty much the same. The poor appetite, overeating, trouble concentrating, trouble falling asleep. Interview staff from all shifts who know the resident best. And the same coding guidance applies when you're interviewing staff as if you were talking to a patient. If there are different frequencies for multiple questions on the same line, you code the highest frequency. If the staff cannot figure it out between the two frequencies, you code for the highest. All interviews are to be completed on or before the ARD. Be sure that you use your in-progress list to stay up to date on any changes to ARDs that may have changed. I have activated a standalone PHQ-9 in PCC for you to use when appropriate. So just like the BIMS, there's now a standalone PHQ-9 that you would use. There's not going to be a protocol for how frequently I or anyone else expects you to complete these, but rather an expectation that you know when you should. Just as your BIMS less than 13, you will immediately alert the MDS coordinator when your PHQ-9 is greater than or equal to 10, so that they consider an IPA or an early OBRA assessment for your case mix. And of course, this doesn't change your need to complete the PHQ-9 with any of your MDSs. I suggest heightened awareness and consideration of additional PHQ-9s in the following situations. So the 30 days for any new admission, and then you would continue it if it was appropriate. 30 days for a resident that's had a significant change scheduled, and then continued if appropriate. 30 days for any resident that has a new or significant weight loss. We often can correlate depression with weight loss. So if you're seeing the weight loss first, maybe that is because of depression. So doing additional PHQ-9 can benefit the patient as well as benefiting you from a revenue standpoint. 30 days for any patient with new psychiatric diagnosis or medications. Someone starts them on an antidepressant or gives them one of those diagnoses, then you may very well want to be looking to do a new PHQ-9, even though it's not time to do one for an MDS. 30 days for any resident that the staff identifies that there's been a change in mood. So if there starts to be conversations about this through morning report or other meetings, then you would want to take a look at doing another PHQ-9. Medicare patients who've had an 8 or a 9 on their last PHQ-9. Remember, the goal would be to get a 10 to be able to capture the depression. Any resident with frequent or constant pain. Just like weight loss, we can associate the pain. If you're in pain, you too would be depressed. That's something that's very depressing if it's frequent or constant and you can't get rid of that. And then hospice patients. Discussions during any of your standard of care meetings should assist you with identifying potentials for change in mood and then trigger you to look at doing a new PHQ-9. So now the 8 ball says you got this. Please complete the mandatory survey for social workers that will accompany this webinar. Thank you and have a great day.